Well, we're going to make it short and sweet. Why we're interested in mitral regurgitation is about the prevalence of disease, and if you look at this one on the right side, it's the prevalence in the community, and the orange curve is the curve of mitral valve disease. So you see that mitral valve disease, dominated by mitral regurgitation, is the most frequent valve disease. And on the left side, the yellow one is the mitral valve disease, and is again in the population where systematic echoes were done. It is mitral valve disease, which is the most frequent in the population. So in the Ox valve, that experience has been duplicated. The Ox valve was in people 65 and above, systematic echoes done in the community. And what they saw is that in red on the left side was the newly discovered valvular heart disease of moderate or severe nature, and you see that it is increasing with age. And you see on the right side that the hemodynamic valve disease is dominated by mitral regurgitation. So similar information in the U.S. and in the UK, and if you make a little calculation about how many MR there are in the population, how the population will grow, how the older population will grow, then you see that in 2000, there were 3.6 million people in the U.S. with MR in the general population, and 2.1 were diagnosed. And this will evolve over time and increase. Around 2030 will be more than 6 million people with MR in the population, and 4 million of them will be diagnosed. So it's a very large population and an increasing population. Now, what do we do with it? How do we as physicians in the community manage mitral regurgitation? And to do that, you'll see some details when Dr. Dziazko will present her expanded data on the mechanism and etiology of regurgitation. But this year we looked at MR in the community. And why do we look at Olmsted County around the Mayo Clinic is because there is one echo lab, and we diagnose all the cases of mitral regurgitation in the community, and it's very easy to look at their outcome and judging their outcome and who gets operated or not. And in particular, it's a community which is very interesting because almost everybody is insured, and all the means of treatment of mitral regurgitation are there. You don't need to have a car. You can just walk to anywhere you want for the treatment. So it's very simple. So what do we see in Olmsted County with mitral regurgitation? We see that the average age at diagnosis is 73. And so it is not, we thought that mitral regurgitation was younger, but it's an elderly population of as many women as men. And you see that there is approximately 40% with reduced ejection fraction. And when we look at outcome, we see that overall the outcome is characterized by excess mortality in all the patients. And you can tell me, okay, well, the EF is reduced in a number of patients. But even if we divide by low ejection fraction, high ejection fraction, you can see that there is excess mortality in every subgroup. But the most important information is that in this population where everything is accessible in terms of treatment, every mean of diagnosis is, you see the treatment at the bottom. Overall, we operate ever in their lifetime only 15%. So if we did the same thing in pneumonia, that we did not treat pneumonia in 85% of people with pneumonia, we would be in terrible shape. We would get we would all go to prison and never come back. So we have a tremendous undertreatment of mitral regurgitation. So if we think about the burden of mitral regurgitation, it is enormous. It is highly impactful on outcome. It is seriously underdiagnosed in the population and seriously undertreated. So imaging has an enormous responsibility in diagnosing MR, in keeping the diagnosis, in alerting the clinician, and in bringing these people to clinical attention. Now, when we do the imaging, the big thing is to distinguish organic MR from functional MR. Organic MR is a serious valve disease with ventricular consequences, and functional MR is a ventricular disease with valve consequences. So one example of organic MR, a bileaflet flail, a serious one. And here an example of serious functional MR where the leaflets are structurally normal, but they don't touch because of the ventricular alteration, in this case an inferior MI. Now, in the old days, there was a guideline on how to quantify MR, and we redid the guidelines last year. This is the title of the paper in the US. And, you know, they're all friends of mine. So we were all in the same committee, meeting and being pleasant and talking. And I've taken a picture of one of the committee meetings here. Yeah? And so, so there was a little bit of tension.
To be a fly on the wall.
A little bit, no big deal. Some tension. But this is the sort of framework, new framework of grading, and not everybody was in agreement with that, of saying, okay, yes, if you see signs that it's very mild, a tiny bit of jet, it's okay. But there was some variation in how we deal with the rest of the MR, and this grading, we are very much for the quantitation of MR. And the interpretation of the measurements is dependent on which disease it is. In organic MR, we have natural history of the disease showing that the people who have a regurgitant orifice above 40 have the highest mortality, and that's one case. But in functional MR, there is data saying that the people who have a regurgitant orifice above 20 are those with a higher mortality. So evidently there is a big discussion about different grading format. Now, to close on the functional MR, you had this paper that was published yesterday in the New England Journal of Medicine about the interventional treatment of functional mitral regurgitation. And here are listed the complication in the people randomized to the interventional group versus the non-interventional group. A gigantic rate of complication at 1 year, 80% in both groups, no differences, and the survival is exactly identical in both groups. So there is a lot. Normally, that's my wife calling me in the middle. Whenever I present, that's my wife calling me. Huh? So for functional MR, there is a great uncertainty. The two committees, the European and the US, have a discordant assessment of the severity grading for functional MR, and there is a disappointing surgical data in the past, and now interventional treatment in percutaneous treatment of functional mitral regurgitation. So it is clear that we need more data on functional MR, its comparison to organic MR. Why do we need to have a different scale? How it should be done? And we need to have more data, and we'll have more data on the treatment using COAP that will be published soon in November, I think. Now, what about organic MR? And here is an example of organic MR. The situation is very different. The main determinant of outcome is valve repair. We've seen a flail image anatomy, and this is the treatment of a flail leaflet, resection, and repair, the standard surgical treatment. And the beauty of valve repair in these patients is that it's the survival line in blue, and the survival line in blue is better than the red survival, which is valve replacement, and identical to the expected survival. So the beauty of valve repair is that when you do a valve repair for degenerative MR, for organic MR, we restore life expectancy. And this is an unheard of result. So when should we refer the patient? And the main indication of valve repair is degenerative MR, which you will see represents approximately 70% of organic mitral valve disease with excessive movement. There are different types of degenerative MR. Now, one group that doesn't need to be referred for valve repair is this one. This is mid-late systolic mitral regurgitation. You see that the signal of MR does not occupy the entire systole, and these patients have generally a benign outcome. It's the orange curve. They have few complications, and these patients generally don't need to be referred, and they do not warrant immediate repair. You have to pay attention to that because the flow convergence looks the same in the holosystolic on top and in the mid-late systolic at the bottom. The jet looks the same in the holosystolic and the mid-late systolic, and it's only the continuous wave Doppler that tells you it is mid-late systolic. Be careful. Don't push this guy towards surgery. Be very careful. And so in the holosystolic MR, we measure more the effective regurgitant orifice than the regurgitant volume. In the end-systolic MR, you have to pay attention to the regurgitant volume because the effective regurgitant orifice is meaningless. So we were on the quantitation of regurgitation, and we think that quantitation of regurgitation should be applied. This is the PISA, the most used method for the quantification of MR. This is an eccentric jet of MR. It's feasible in most patients. You can measure the effective regurgitant orifice. And when we did the prospective studies that we published in the New England Journal of Medicine, it was the main predictor of outcome of survival after diagnosis, but also of cardiovascular events after diagnosis under medical treatment. After surgery, the effect disappears. But the method of quantitation from that, the grading is in the SE grading, the words, all the angiographic grading and the numbers are the same. So if you say severe, it's grade 4, and it's 60 of regurgitant volume and 40 of regurgitant orifice. And that's the grading that has been maintained in both European and American guidelines. However, over time, this method has been criticized. Oh, it's too difficult. We can do it in my grandmother. I don't have time. I'm too busy. I'm blah, blah, and all that. And so, okay, how does it work in routine practice? How do we do it in routine practice? And we published this year in Circulation this paper on what it is in routine practice. So what we did is we take not just the patient that I did the echo, but everybody. Every single physician and sonographer we took, and there were 6,000 patients with mitral valve prolapse and MR, and of those, 3,900 had quantified mitral regurgitation after some exclusion. And when you look at that, what is amazing is in routine practice, the number that is in the report is highly predictive of survival under medical management after diagnosis. It's not just me, it's everybody. More than 30 physicians, more than 100 sonographers, and it is everybody, and that's what predicts the outcome of this patient. And it's probably the most important curves we've ever done. You see here is the relationship in the spline curve of mortality compared to expected. So the red line is the population mortality. So if you live as long as you're expected to, you're on 1. And when you look at this population, the people without MR and those with MR below 20 of regurgitant orifice are in green. They are not different from 1. Their life is as expected for the general population. No excess mortality. But what is interesting is that after that, the beige and the red, there is excess mortality starting at 20, progressively increasing in the moderate range, and increasing even more after that moderate range, and continuing to increase. And what that means is that it's not sufficient to say it's severe, because somebody with 40 of regurgitant orifice or 80, they don't have the same prognosis. So it's not sufficient to say, oh, it's severe MR. I see a big jet, it's severe MR. No, you need to put in the report, it is severe, and the regurgitant orifice is 0.45. It is severe, and the regurgitant orifice is 0.95. And if the moderate, the same, because somebody with 25 in the moderate range of regurgitant orifice, 0.25, is not the same as somebody with 0.35, because the excess mortality is much higher. So we need to report two things. The integrative grading, our impression, very important to communicate, but also the number with it that we need to report. But it should influence the treatment. And then the last thing on this one is that the moderate MR is not so benign. Some patients in the moderate MR have excess mortality, and we need to study them, to do clinical trials in them, to see if treatment of these patients will improve their outcome. It is not a benign subgroup. So I'll let you think about it. So quantitation of MR, scalable in routine practice, determines the MR survival, is incremental to MR grading, and defines the crucial moderate MR range that we need to treat. Now, is it worth it to do early surgery when people are asymptomatic? We believe so. When we studied in the MEDA trial, it was published by my former colleague Rakesh Suri, there is a better survival and less heart failure in people who have early surgery versus the people who are followed medically. And so what do I do for somebody who is asymptomatic? When there is no risk factors, I'm going to list them. We follow this patient, and the more MR there is, the more closely we follow them. When the people present with what is in the guidelines, LV dysfunction, atrial fibrillation, pulmonary hypertension, we're not going to deny them surgery. We're going to do the surgery, but it is a rescue surgery because, yes, we do it, but there's going to be a price to pay after the operation in terms of mortality. And then if people don't have those symptoms and atrial fibrillation, then there are a number of quantitative criteria that we measure during the echo, in particular the effective regurgitant orifice, but other things that tell us, let's go now because we're getting closer to a point where there's going to be a risk to the patient, and then we do an early repair, early surgery. Well, I limited my remarks to what was published in 2018. Thank you so much for your attention. Thanks.
Thank you, Maurice. That was a wonderful overview and bringing us up to date. Does anyone have any questions? I don't see any that have come up here. Please identify yourself.
Anil Bansal from Dubai. I just wanted to know the dimensions of end systolic dimensions of 45 millimeters. How far is it still relevant in asymptomatic MR?
It is very relevant. End systolic dimension is a continuum. 45 is very late.
So 40
is a very late. I know that there is a divergence between the European guidelines saying 45 and the US guidelines saying 40. What we see is that, and we've shown that in the MEDA study registry, is that the people who have 40, more than 40, incur mortality now, excess mortality now. So somebody who is at 40, 41, 42 already has a risk now. Now, if you do surgery in these guys, they're going to survive, but they're going to pay a price in postoperative outcome. So we prefer to operate before the 40, when people are 36 to 39, because at that point, they have a good outcome, but they're getting closer to having LV dysfunction. So yes, end systolic, I could not mention everything because otherwise we needed to stay until tomorrow. But it's a very good point. End systolic dimension counts.
And is there a correlation between the ERO and this?
No, it's the response of the patient. It's not the most severe. Sometimes you see somebody who's just barely severe or moderate, and they have an end systolic dimension. It's the response of the ventricle of this person. When we do the whole genetic study, maybe we'll understand why somebody responds poorly and has a large end systolic dimension, and why others can tolerate MR with a good LV function.
Okay, thank you, Maurice. I think we need to continue, and maybe your question we can get at the end.